Hi everyone, my name is Rebecca Hajos, and today I'll be exploring the healthcare infrastructure challenges facing Native American reservations through the lens of systems theory. As a registered nurse, I've seen firsthand how gaps in healthcare delivery can affect patient outcomes, but today we'll zoom out and look at this issue as a part of a larger interconnected system. We'll explore the stakeholders involved, feedback loops that perpetuate disparities, and potential leverage points for meaningful change. By applying systems thinking, we can better understand not just the problems, but also how solutions in one area can ripple across the system. Healthcare on many Native American reservations faces longstanding challenges. Clinics and hospitals are often underfunded, understaffed, and geographically isolated. These infrastructure gaps contribute to higher rates of chronic illness, such as diabetes and kidney disease, and lower life expectancy, especially compared with the general US population. From a nursing perspective, I see that human impact of these systemic gaps every day. Patients delaying care, medications running out, and a general sense of frustration and distrust in the system. Understanding these disparities isn't just about numbers, it's about recognizing how the system itself produces these inequitable outcomes and why a system's perspective is also critical. So who are the stakeholders? Well, when we examine the healthcare system on reservations, there are multiple stakeholders, each with different roles, responsibilities, and priorities. The Indian Health Service provides federal healthcare services, but funding is often limited. Tribal governments and community leaders work to fill gaps and advocate for culturally appropriate care. Federal policymakers and funding agencies influence how resources are allocated, often creating bottlenecks or delays. Healthcare providers, including people like nurses, physicians, and community health workers, deliver frontline care. Finally, community members and advocacy groups push for equity and access for all. All of these stakeholders interact in complex ways, and understanding these relationships is key for applying systems thinking. Systems theory. So what is systems theory? Well, it's a framework looking at problems as a part of an interconnected web rather than isolated events. Systems theory emphasizes relationships, feedback loops, and the way small changes in one part of the system can produce big effects elsewhere. For global health and healthcare infrastructure, it helps us see beyond individual clinics or policies to the larger structures that shape outcomes. So as a nurse, I naturally kind of think in terms of direct patient care and individual health, but systems theory pushes me to consider the wider social, political, and institutional forces that affect health across entire communities, like Native American populations. So when we're defining the system boundary, when applying systems thinking, it's important to define that systems boundary. So the one that we're examining for this presentation, we're focusing on healthcare delivery and support networks for Native American populations who are living on reservations. This includes the Indian Health Service, tribal clinics, and the connections with state and federal agencies that influence funding, workforce, and policy. While every reservation is unique, this system boundary allows us to kind of analyze patterns, relationships, and feedback loops that affect access, quality, and outcomes. Defining these boundaries like this also helps us clarify which elements are inside the system and which are external influences such as national healthcare policy or social determinants like poverty. So what are the system elements? Well, now that we've defined the system boundary, let's identify the key elements. Infrastructure includes the physical clinics, like hospitals and equipment needed to deliver care. Workforce covers nurses, physicians, and community health workers. Without enough trained personnel, services cannot reach those who need them. Policy and funding, such as the IHS, the Indian Health Services, Appropriations, grants, and tribal governments' decisions dictate what resources are available and how they are distributed. Cultural and linguistic factors like trusting in healthcare providers and integration of traditional medicine influence whether community members actually seek care. Finally, social determinants like poverty, education, housing interact with the healthcare. Shaping access and outcomes. As a nurse, I can see how these elements combine to create both visible and hidden barriers to care. So relationships and feedback loops. Here is kind of where we begin to see the power of feedback loops within the system. For example, chronic underfunding leads to workforce shortages. This leads to reduced access to care. And then in turn, this worsens healthcare outcomes, creating an even greater demand on the system and further straining limited resources. Another reinforcing loop involves trust. A history of inequity and cultural misunderstanding fosters distrust, which delays care and increases cost, reinforcing the cycle of poor outcomes. Again, as a nurse, these loops are very real. The patients I see are often experiencing delays or fragmented care, which not only affects health, but erodes confidence in the system. I keep thinking of patients who are coming from the Black River Falls area to Eau Claire, Wisconsin to receive care and how far they have to travel. And when they finally get here, they often just feel so overwhelmed and don't have a great understanding of their healthcare issues that it's very seldom that they return and continue that follow-up care. This kind of speaks back to that lack of trust, the delayed care, the higher costs, and then that lack of solution, it leads to further distrust. This reinforces cycles that perpetuate inequities. So systems thinking helps us map these relationships to identify where interventions could break these cycles. So visible versus hidden interconnections. So not all system connections are obvious. Visible issues include clinic closures, limited staff, and delays in funding, but hidden interconnections can be even more important. So we have things like policy inertia, structural inequities, and lack of tribal representation in decision-making influence how resources are allocated and whether interventions succeed. Recognizing these hidden elements is a core principle of systems thinking. As a nurse, I often see the visible consequences, but understanding these hidden dynamics allows us to identify meaningful leverage points, places where small changes can ripple through the system and improve outcomes. So here is where I have a systems map. This slide shows this visual of the systems map, and it summarizes kind of what I've been talking about so far. At the center is healthcare infrastructure, which depends on inputs like funding, workforce availability, policies, trust, and social determinants. Outputs include health outcomes and levels of community engagement. Feedback loops connect these elements. Poor outcomes feed back into funding decisions and community trust, creating reinforcing cycles. This visual kind of helps us see how changes in one part of the system, like for instance, increasing workforce capacity or improving community trust, can positively impact the entire system. And we'll talk more about these leverage points in a later slide for intervention. All right, so examples of systemic change. There are several examples that can show how systemic interventions can make a difference. Something that we experienced during COVID was an increase in telehealth, which is huge, and it's actually benefited a lot of different communities, and specifically the Native American community. Telehealth programs have expanded specialty care and access, especially for geographically isolated communities like the Native American tribal communities. Tribal public health departments have also strengthened surveillance and emergency preparedness, which creates more resilient healthcare networks. Some state-recognized tribes, which are not fully served by the IHS, have developed self-run clinics tailored to their community needs, demonstrating the importance of local, culturally competent solutions. If we can kind of empower these communities to create solutions for themselves, they're going to be better received. So these examples illustrate that interventions at different points in the system, policy, workforce, or infrastructure can have a cascading positive effect. So what are these leverage points for positive change? Well, excuse me, systems thinking highlights leverage points. Areas where targeted changes can produce large-scale improvements. Increasing direct federal funding can strengthen infrastructure and expand the workforce. Supporting tribal self-governance allows communities to make decisions that reflect their cultural and practical needs. Culturally competent telehealth programs reduce geographic and trust barriers. Finally, partnering with universities or research institutions can provide resources, training, and evaluation to sustain improvements. As a nurse, I see how these interventions directly affect patient care experiences as well, from improved access to enhanced trust with healthcare providers. Also, other things that we could consider is something that Viterbo University independently has been doing as well, or had done in the past, I should say, which is a clinical experience for student nurses. I believe that was at a South Dakota reservation where students can interact directly with these communities, get a wider view of what's going on, and then also kind of create a point of trust with these communities as well. So in conclusion, the healthcare system on Native American reservations is really complex. There's multiple stakeholders, feedback loops, these hidden interconnections, but systems thinking allows us to identify reinforcing cycles of inequity and hidden barriers that might otherwise go unnoticed. We need to find effective interventions that must operate at multiple points, from funding the workforce development to allowing for more culturally competent care and community engagement. Putting the power into the hands of the locals is going to really ultimately, do the most good. These solutions work best when they are community-led and culturally grounded. I'm inspired by the ways frontline care policy and community action can come together to produce real systemic change. Thank you for your time. Here are some references that you can review and that I utilize throughout my presentation. And if you have any further questions or concerns, I'd really love to chat more. You can reach me at the information shown here. There's my email and my phone number. Have a wonderful rest of your day. Thank you so much. Bye.